So thank you so much for joining us. This event was organised by the Person-Centred Care Programme of the International AIDS Society, which is advocating for integrated, inclusive and responsive healthcare services that focus on the changing needs, priorities and preferences of individuals and empowers them to demand services that respect their identities. This is the first meeting of the Person-Centred Care Research Collaborative for 2026, but we have been meeting since 2024. The Person-Centred Care Research Collaborative has the mission to work collectively and efficiently to fill evidence gaps around person-centred care for people living with HIV or vulnerable to HIV acquisition. And we are doing this by convening around 3 to 4 times a year researchers, clients, healthcare providers who are championing evidence generation related to client-provider relationships, participatory approaches that value experts by experience, as well as specific research and policy gaps related to person-centred care within the HIV response. And the quality of the work included in the publication that was of the GIS supplement just last September on person-centred care approaches to HIV prevention has prompted us to want to convene these co-authors over the next 2 days. So we have a meeting one today focused on evidence from Africa and North America. And then tomorrow we'll have a follow-up meeting focused on the evidence from Asia. We wanted to be inclusive and have all the co-author teams represented and also to respect people's time zones. So that's why we're doing this kind of meeting over 2 parts. So just a quick reminder of standard kind of Zoom meeting protocols. This is a meeting, not a webinar. So please stay on mute unless you are presenting or the moderator calls on you. Use the chat to ask questions. The idea is this is a reasonably small group, so it should be quite an interactive meeting. After the presentations, there'll be an opportunity for discussion and questions. So during that time, when we get to the discussion part, if you would like to raise a question or provide a verbal comment, please raise your hand. So I'm pleased now to introduce today's moderator, who is one of the 3 guest editors of the supplement, Marie-Claude Lavoie. She's an epidemiologist and assistant professor in the Department of Epidemiology and Public Health at the University of Maryland School of Medicine in the United States. So the floor is yours, Marie-Claude. Thank you.
Thank you, Emma, and thank you to IAS for inviting me to be part of this meeting. So good morning, good afternoon, good evening, depending on where you're joining us from. So welcome, everyone. We're very thankful for having you join this meeting. So we have a community of researcher, practitioner, policymakers that are dedicated to advance the science and the implementation of person-centered care. So today's objective is to identify the evidence-based strategy and future research gap with regards to person-centered care prevention for people vulnerable to HIV acquisition, with a focus on recent evidence from JIS supplement. As Emma mentioned, the JIS supplement was published in September 2025. We received over 100 submissions for this supplement. So this speaks volume in terms of the interest and the relevance of the topic. And a special thanks to the guest editor, my colleagues Andrew Mujira, as well as Iskander Azwa, the guest editor, as well as the supplement editor, so Camille Kourouvadou and Loza Birou, for their leadership and guidance in this supplement. So in terms of the supplement objective, 3 main objectives. So first, to disseminate new evidence to scale up person-centered HIV prevention intervention, service, and products. Second, the scope included the integration of HIV prevention service with those with hepatitis and TB, as well as sexual and reproductive health. And selection was prioritized contribution that evaluated novel strategy, including within demedicalizing setting to overcome or circumvent structure and legal barriers to improve access to prevention services and ensure effective linkage to care among marginalized groups. So when we look at the supplement as a whole, I think three main themes emerged from the selected paper. So one of them was the focus on overcoming structural and health system barrier to access HIV prevention and treatment. The second one was intervention center on delivering integrated services beyond the traditional healthcare system. And the third one focused on digital health innovation, solution, tools, and system. And for the person-centered collaborative, we also see 6-9 themes that emerge in terms of the new evidence. So first, informed, effective choice is highly valued by clients. We think about PrEP now, individuals have different choice, different option. Oral PrEP adherence is often suboptimal, but encouraging use that can be increased through the use of digital tools to support adherence. Diverse demand for long-acting PrEP formulation exists. Safer supply of opioid can reduce HIV and hepatitis C acquisition with broad trauma-informed care, so really integrated care. Status neutral, appropriately integrated and inclusive primary healthcare and harm reduction services are key. And gender affirming care can act as an opportunity, as an entry point to offer broader service, including HIV prevention. So what do we have ahead of us? So we have a very distinguished panel. So first, we'll hear from Shauna Dalal from the World Health Organization on harnessing digital health data for person-centered HIV prevention monitoring. Yeah. Then we'll hear from Anke Rotzark on oral pre-exposure initiation, continuation, and adherence among pregnant and postpartum women receiving antenatal and postnatal care, a systematic review, followed by Mariam Shamanesh on person-centered HIV prevention and care for youth in rural South Africa, followed by Adrienne Gutta from an HIV, a hepatitis C and HIV point of view. It's been remarkable, a qualitative study about using prescribed safer supply to support people who use drugs. And then we'll have a panel discussion followed by a Q&A that, as Emma mentioned, this is a small group, so we hope it can be interactive and dynamic to have conversation about how do we advance the science and the implementation of person-centered care. So Shauna, over to you.
Thank you so much. I'm just going to share my screen. Please let me know that you see the correct screen in full screen mode.
Yes, it looks good.
All right. Thank you so much for the introduction. Today, I'm going to talk about HIV person-centered prevention monitoring. So I'll first describe the WHO guidance that we have on person-centered HIV strategic information. Then I'll cover this country survey that we did to look at the availability of data elements for prevention monitoring in national surveillance systems. And I'll discuss also briefly a review of the global AIDS reporting on the use of unique identification for key populations. So these guidelines, the consolidated guidelines on person-centered HIV strategic information were released in 2022 with several different components, with an emphasis on having routine data and strengthening national systems for recording information. So there are 22 data recommendations that focus on individual level data to support prevention, testing, and treatment programs. They focus on better integration, including for TB, STIs, viral hepatitis, and cervical cancer. They also mention and focus on the use of routine data for HIV surveillance to track the epidemic, response, and impact, and overall emphasize the importance of building a secure, interoperable digital data system. A founding principle of the guidelines is the use of a minimum data set that captures key events in an individual's interaction with the health system. And I'll just describe that shortly. And then finally, we have priority indicators for program management and monitoring that are based on that minimum data set. So this is the minimum data set for HIV prevention. Now, a standard minimum data set has been part of practice for treatment for years, decades. But this is the first time that anyone has released a minimum data set for HIV prevention. And as you can see here in the table on the right, what we have is the intervention. So starting from testing and then a list of all the different prevention interventions. And on the right is the minimum data elements that are required to collect information in order to calculate indicators. So for example, for pre-exposure prophylaxis, you need to know the date that PrEP was prescribed. So it records the date of the event as well as the event itself, the date it was dispensed if that's available, but that is not a necessary one. The PrEP product that was prescribed, whether it was oral or long-acting, the volume that was prescribed, and the future dates for follow-up appointments. And with this information, one can collect and calculate several different types of indicators for any different purpose. So there are several uses for individual level data on HIV prevention. The first is by service providers to improve the management of individual clients. The second is to construct HIV prevention cascades. And the third is aggregating individual level data to report on prevention indicators. And although we emphasize the use of individual level data for prevention, we also include guidance on how to report on indicators in the absence of that and to be able to use aggregate program data. For a system to be able to collect individual data on HIV prevention, there are several different requirements, which I've listed here. The first is unique identification to track individuals within a service and ideally across different services to allow for deduplication. This has been a challenge for prevention in particular because people can start and stop prevention at will or as their risk changes over their life course. The second is the ability to identify individuals and priority populations who may benefit from HIV prevention. The third is to collect this minimum data set of essential elements for monitoring. The fourth is having standardized data collection and tools and processes across service delivery points. And the fifth is to maintain confidentiality and security, particularly for key populations. So all of these details are given in the digital adaptation kit for HIV. We have a second edition that was released, as you can see here, in 2024. And in the Web Annex A is the data dictionary and Web Annex C is the indicator table. And what these do is describe in great detail the data elements that are required and the indicators that can be calculated based on those data elements. So for this work, we did a survey of 21 countries that were attending a workshop on prevention monitoring. And we assessed their availability of 42 data elements required for HIV prevention monitoring in their national surveillance systems. So this covered registration, HIV testing, prevention, and vertical transmission. And then looking at the data elements that were there, we looked to determine which of these could be used to calculate HIV prevention indicators. And then we also reviewed the global AIDS monitoring reporting on unique identification for key populations. So starting with availability of registration data and unique identification, you can see that about 83% of countries had some form of unique identification. But the most commonly used form was a program identifier, such as an ART number or a number for HIV prevention, that particular service. And the disadvantage of that is that it doesn't translate across areas. So for example, across STIs to be able to use it differently. Several also use national unique IDs, which is not suggested for health data. In terms of demographics, even date of birth and sex were not universally collected. And for key populations, sex workers and men who have sex with men were able to be collected in more than some of the other key populations. Now, looking at the method for unique identification for key population prevention, out of 105 countries who responded to this survey, several of them, very few though still, used nationally harmonized unique identifiers. And several still used unique identifiers at a national level. And of concern, 12, up to 12 of them use a combination of personal identifying information. Biometric use was very rare. So now coming to the point on indicators and how we can use these to calculate indicators. So this table, the colors represent the different types of prevention. So you've got condoms and PrEP in blue, the needle syringe programs in OAMT in purple, testing in orange, and down at the bottom in yellow is vertical transmission. And in the red box, what you can see here is all the different data elements required to calculate a single indicator. For example, for PrEP coverage, you need all these different pieces. So for each indicator, it's not sufficient to just have one data element, but in some cases it is. So some are more complex than others. And what you can see here is that overall, it was quite good data collection, data element availability for PrEP and PEP and condoms, but really for needle and syringe programs and OAMT for people who inject drugs, those were very low and uncommon, even in countries which had programs. So several countries didn't have programs. And when we took out those that didn't even have programs or didn't report programs, even so, they were quite low. But really, the lowest was this one HTS7 in the bottom red bar, which is the linkage between HIV negative testing and prevention. And only 2 countries were able to collect all the data elements required for that linkage indicator. And the reason it's important is that when someone tests HIV negative, we need to be able to see within the system whether they actually accessed any prevention, and therefore all the different prevention interventions must be listed in order to calculate that linkage. So in conclusion, countries are at varying levels of data element availability in their HIV prevention response. The use of unique IDs was not universal. And as I mentioned, program-specific IDs are useful for monitoring individuals, but they're not helpful for cross-disease linkage for other areas. And using a unique ID for health without personally identifying information is what's recommended so that we don't identify people just on the basis of the ID itself. There was good availability for several data elements on condoms, testing, PrEP, and vertical transmission, although there were still some gaps, but very limited for needle syringe programs, OAMT, STIs, and behavioral data elements. And then, of course, all countries reported plans to update their health information systems, and so we're looking forward to monitoring that in the future. So in the future, routine data are going to continue to be critical for long-term sustainability of prevention monitoring, particularly given the current environment and reduced funding. So as WHO, we will continue to encourage the inclusion of data elements in national systems, monitor progress towards their inclusion, and the calculation of data elements, and particularly to make sure that in these times that data security and confidentiality are maintained. And we'll also be releasing updated guidance on HIV surveillance this year that will include some information on long-acting PrEP. Thank you. I'm sorry, back to you, Emma or Mary Claude. I'm not sure if you can hear me. Okay.
Yes, thank you. Next speaker is Anke Ratzar. She's a public health researcher at the Sexual Health, including HIV, unit of the Institute of Tropical Medicine in Belgium. Her research focused on HIV prevention with a particular emphasis on integrated PrEP care and STI testing for pregnant and postpartum women. Anke, over to you.
Hi, thank you for the introduction, Marie-Claude. I don't know, Emma, if you're sharing the slides.
Yes,
see
can you see them?
okay.
Or?
No, I
Oh,
see a black screen.
Okay, let me
I don't
try
know
again.
for the others.
Yeah. Is it working now?
No, but if it's not working, I can also try and share my slides. That helps.
Still not working?
Not really.
Okay. Sorry. It was working perfectly.
Yeah. Let me share my slides.
All right.
If I am able to do that. Yeah. Okay. I send a request for sharing.
Should be all good.
Yeah. Okay. And then I'm presenter mode and it should show. Is this visible for everybody?
Yes, sure.
Okay. So yeah, thank you for the opportunity to present the work of this systematic review, which shares some insights about oral pre-exposure prophylaxis among pregnant and postpartum women when they are attending antenatal and postnatal care. I want to start with giving some background information. So globally, 1 in 4 child HIV infections result from maternal HIV acquisition during pregnancy or breastfeeding. And in Eastern and Southern Africa, this is even 1 in 3 child HIV infections. So this means that maternal acquisition, HIV acquisition not only poses a threat to maternal health, but also to the perinatal health, so the outcomes of the baby. However, these infections, we can prevent them because, as I said, there is oral pre-exposure prophylaxis, which is safe to use and recommended by WHO for pregnant and postpartum women in settings with high HIV burden. But what we see from data collected is that it's being underused among this population. So how could we then reach these pregnant and postpartum women? When we look at antenatal and postnatal care, we can see there's a high coverage of these visits. For example, in Eastern and Southern Africa, 86% of pregnant women attend at least one antenatal care visit. So you could look at this first ANC visit as really an entry point to educate or to talk about HIV prevention with these women. So therefore, myself and the co-authors of this systematic review, we were interested in summarizing oral PrEP use among these pregnant and postpartum women when they are being offered it through antenatal and postnatal care. So what did we do? We searched all 3 databases and we looked for English language quantitative studies, which were published between January 2015 and March 2024. We had no geographical restrictions, but PrEP had to be delivered through antenatal and postnatal care. If it was through community-based delivery or something else, they were excluded. Or if they were part of a clinical trial, which were not focusing on this route, they were also excluded. They also had to report on the following outcomes, so either initiation, so uptake, continuation, or adherence. And the systematic review yielded 481 records, and then we included 12 full-text articles. And these is the list for your information, maybe for afterwards. You can go through the list if you're interested of the 12 records we included. Some study characteristics of the records we included is that so we had 12, but actually they pertain to 6 parent studies. Of the 12 records, 5 were from South Africa and 5 from Kenya. 6 were cohort studies and 4 were randomized controlled trials. And the majority reported on continuation and adherence. There were about 100 up to 9,000 participants, depending on the study. And at recruitment, the median gestational age of the women were 20 to 26 weeks. But follow-up period really varied between studies. So for some, this was 1 month post-enrollment, mostly for the pilot randomized controlled trials, up to 12 months postpartum. So you can see there's some variability or heterogeneity in the studies already there. If we look at the initiation of the initiation outcome, which was reported about in 7 of the articles, initiation was defined as accepting initial prescription or as self-reported use at the follow-up visits. And uptake really varied from 14% up to 84%. And notably, there was a higher uptake among women with increased exposure to HIV in the sense that they were either diagnosed with an STI or they had a partner living with HIV. For continuation, here the definitions were receiving a prescription for PrEP, self-reporting PrEP use at the follow-up visit, or the participant presenting for the next study visits. So here again, variety in the definitions and the measurement of continuation. But what we can see is that post-enrollment, I don't know if you can see it, but on the top there's, after 3 months post-enrollment, there's already a huge drop in continuation. Half of the women already stopped, and here in Kenya, only 1 in 4 or 5 continued at 3 months, and the decline. The declining trend was even worse 6 months later, post-enrollment. For adherence, this was reported either self-reported or objectively measured adherence. With self-reported, for example, this could be the number of doses taken in the last week or in the last 30 days before the visit. For the objective measured adherence, this was tenofovir measured in urine or tenofovir diphosphate in dried blood spots. And what we generally saw is that self-reported adherence was quite high, and the objectively measured or adherence was showing us inadequate levels to effectively prevent HIV acquisition. This is a screenshot of one of the tables in one of the articles, and the light gray, for example, is the 7 doses a week self-reported, which is quite high proportion compared to if you then look at the black bar, which represents the 0 to 2 doses per week measured objectively. You could see there's a huge discrepancy between the two. So all in all, there was suboptimal adherence throughout pregnancy and the postpartum period based on these results. Sorry. Our systematic review had some limitations, so we focused only on oral PrEP. So we excluded papers, although there were not a lot, papers on vaginal ring or the long-acting PrEP injections. As already mentioned, there were varying definitions for PrEP use outcomes, so comparability was not that easy and prohibited also a meta-analysis of the outcomes. We have a limited geographical scope, so mainly Kenya and South Africa, which then limits the generalizability towards other countries and settings. And there was a lack of long-term follow-up, which then restricts the understanding of the long-term PrEP continuation and adherence. But all in all, I think this systematic review shows us some insights into PrEP use and shows us that there is some promising initiation proportions, so that ANC can be a promising approach to initiate or to educate and introduce HIV prevention, particularly PrEP, among pregnant and postpartum women, but that there are substantial challenges in continuation and adherence. So there's a need for more person-centered supportive interventions. There's need for expanding access to long-acting PrEP options. And also there's a need to investigate differentiated models of delivery, especially in the postpartum period. As we saw, there's a huge decline in that period of the lives. We were also requested to have a slide on current and future research. So these are the studies that myself and the co-authors are involved in. So myself and Dr. Bernadette Hansen, we are involved in looking at PrEP use in pregnant and postpartum women in Zambia. Shannon Bosman, she's involved in the Do PrEP and Expressive 10. In the Do PrEP, they look at differentiated clients and PrEP delivery models among adolescent girls and women, including those who are pregnant and postpartum. For the Expressive 10, they're evaluating the once monthly oral PrEP, and they're not excluding women who become pregnant during the study. For the Scope, PP, and the Prepare to Choose, these are studies from Dora Joseph Davy, and they look at client-centered choice in PrEP and HIV testing delivery in South Africa among pregnant and postpartum women on oral PrEP. And the last one is looking at evaluation of PrEP choice, and they hope to extend or to include lenacapavir in this year in the study. And these were some fresh from the press, how do you say it, results from the person-centered PrEP delivery study, which shows that offering dynamic choice in PrEP delivery really increased PrEP adherence and continuation in the postpartum period among women, comparing it to enhanced counseling in the clinic. If you're interested in this, you can also look at the abstract, which was presented at CROI a couple of weeks ago. For the research gaps to be addressed related to person-centered prevention service delivery, we had a long list, so I'm not going to read them one by one, but we were mentioning long-acting PrEP, so looking at implementation, looking at sustained equitable models in resource-constrained settings, focusing on the postpartum period, how we can enhance continuation, looking at how digital and AI tools can be used to increase risk identification, choice support, and adherence. And then also we had one on the integration of STI testing services, also considering the triple elimination framework, so merging hepatitis B, syphilis, and HIV. So looking at these points for the future would really help to improve person-centered prevention and care. So the last slide, then I would like to acknowledge the co-authors of this study. So Dr. Bernadette Hansen, Dora Joseph Davy, Zainab Esak, and Dr. Shannon Boston. Thank you all for listening.
Thank you, Enki, for your...
Stop sharing, yeah.
Thank you, Enki, for your excellent presentation and your insight in terms of what are some current existing research gaps. So thank you. And next speaker is Miriam Shamanesh. She's a global health research professor, a physician scientist, and a faculty member at the Africa Health Research Institute in South Africa. Her research interests lie in the interdisciplinary space between social science, clinical medicine, and epidemiology. She enjoys using innovative and participatory methods to develop and rapidly evaluate complex interventions that improve the health of adolescent, youth, and marginalized population. Marianne, over to you.
Apologies, just having a little bit of trouble with the screen sharing, but Cami will share in just a moment.
Okay, you're sharing, then I'll wait. I think we're okay. Thank you. So thank you for inviting. Can you hear me?
Yes, yeah. We can hear you well. Thanks, Mariam.
So thank you for inviting me to talk about this particular cluster randomized control trial and the early implementation findings today. So next slide. Am I moving? And next slide. So I think we all know that despite effective, cheap, and safe biomedical tools, particularly point-of-care lateral flow tests, a pill a day that can prevent HIV transmission, we just talked about PrEP, antiretroviral therapy and napilidate that prevents acquisition PrEP that we've talked about, we have failed to eliminate HIV and we're far off our targets. Next slide. The study setting is a health and demographic site in rural KwaZulu-Natal, right on the north on the border with Mozambique, and the area is very rural and poor with a very high levels of unemployment and a very high burden of HIV, about 40% antenatal prevalence. Next slide. And despite the fact that we're seeing very dramatic declines in incidence, which were driven by antiretroviral therapy and voluntary male medical circumcision, they really seem to have been slowing, and we are very far off the sort of less than 1 in 1,000, which would allow us to say that elimination has happened. And of course, there's now the cuts in funding that can worsen the situation. Next slide. So we were trying to test the population impact of implementing a community-based model of person-centered care. Next slide. And just to sort of point out why we want to do this in mobile sexual health services, our social science team had already found that policymakers, young people and their families were very concerned with sexual and reproductive health of youth, fertility and poor birth outcomes, and they're right. We consistently find high prevalences of curable STIs, and they're mainly asymptomatic. And in fact, in the first randomized controlled trial globally, we showed that home-based STI self-testing, self-sampling and testing, and broader sexual health increased demand for risk-differentiated HIV prevention, particularly PrEP, amongst adolescents by 60%. Next slide. So we built on this to co-create Tetanami Netetanawe. And this was a co-creation intervention developed with young people where young peers aged 18 to 30 who live in areas leverage their lived experience to support community-based HIV testing, treatment, and HIV PrEP. These area-based peer navigators map resources in their communities, mobilize PrEP demand, promote PrEP literacy, and during health promotion conversation, identify the nature and urgency of the need that's then shared through an electronic clinical management system with the clinical and social services. They refer those who would benefit from sexual health services, HIV testing, PrEP or ART to the mobile sexual health services that visit the areas monthly. The Peer Navigator digital tools really allow them to, in real time, integrate their person-centered differentiated care from the community into the clinical and social services. Next slide. So we're testing this in a cluster randomized controlled trial, but here we're presenting the first year, so just the intervention clusters. And in the first year, we reached 3/4 of all young people, nearly half of them young men, in the intervention clusters. Next slide. Here you can see that among the young people assessed, sexual health was the most frequently reported need. And of the nearly 10,000 who were assessed, over 2/5 of them were identified as having medium to high needs and were referred into the mobile adolescent and youth-friendly clinical services. In contrast, we see that their assessments of social support, education and legal needs revealed much lower proportions of medium or high need. But again, the patterns were similar for both sexes, so men and women were quite similar in their sexual health, social, education and legal needs. Next slide. So among the 4,000 individuals who were identified to have medium or high need and were referred into sexual health services, over half of them successfully linked to care. More women, 2/3 of women linked compared to half of the men. Over 90% of the clinic attendees underwent HIV testing, so they successfully received an HIV test result, and there was a similar uptake between men and women. Nearly half needed HIV treatment or HIV pre-exposure prophylaxis, and PrEP uptake was 5 times higher amongst young adolescents and young adults who were high risk, and this was defined as engaged in transactional sex, condomless sex with 2 or more partners, unknown HIV status of their partners, alcohol or drug use during sex, and gender-based violence. So we see that we're reaching a higher proportion of young people with high need and starting them on PrEP. Next slide. There's also a very high level of SRH needs, so a total of 1,500 of the clinic attendees who were tested for common curable STIs, that's chlamydia, gonorrhea, or trichomonas, were gene expert, and a similar proportion overall tested, 2/3 each. Overall, nearly 1/3 tested positive for any sexually transmitted infection, with a significantly higher prevalence among women across all age groups, but particularly a shockingly high level of STI prevalence. This is a community-based population of young people, of 40% amongst 15 to 24-year-old women. Among those who tested positive, though, more than 90% received STI treatment. So this intervention not only tests, but also reaches young people with treatment. And it didn't differ by sex. Again, in terms of contraception use, we see that 2/3 of the contraception users were receiving the contraception for the first time through these mobile clinics. And that's particularly the case for 15 to 19-year-olds, where 70% were receiving their contraception for the first time through these clinics. Next slide. So in conclusion, we think peer-led person-centered care reaches the most vulnerable adolescents and young adults with differentiated biosocial care. Nearly half of the adolescents and young adults referred into mobile services needed either HIV treatment or pre-exposure prophylaxis, and 1/3 of those referred into mobile services had a curable STI. 2/3 of the women needed contraception. This was particularly important for the 15 to 19-year-olds, which we know are a target group to prevent teenage pregnancies. Next slide. So effective HIV prevention not only reduces HIV incidence, it also reduces time to HIV treatment. Peer-led delivery with SRH and social care efficiently provides differentiated care to adolescents and young adults. And in terms of the way forward, we will be presenting the trial, the sort of cluster randomized control trial, which will look at whether this model reduces population-based sexually transmissible HIV, so reducing incidence and improving access to care at a population level compared to standard of care, which is primary care delivery. We'll also be, we've also got a second study, LAPIS, which is looking at dynamic choice, so whether adding in the choice of an injectable, in this case cabotegravir, will improve uptake and retention on PrEP. And finally, this whole model is going to be scaled up to reach priority populations at higher risk of HIV acquisition through peers with lived experience, integrating with SRH, and really bringing in a choice of venue and a choice of product, and in this case, a choice of product as lenacapavir with the Accel, Unitaid-funded Accel proposal, which is starting in the next few months. And so we hope that we can show that at scale, this model will reach those who most need HIV prevention and also allow them to remain engaged, because we're assuming a choice of product and a choice of venue will make it easier for people to start and stay on product. Thank you. And this is just to thank the very large team of people that have made this work possible and the peer navigators that have really driven the work in the community. Thank you.
Thank you, Mariam, for your excellent presentation. So looking forward to the discussion session. Next, we'll have Adrian Gutta. He's an associate professor in Canada, research chair in health disparity and public health in the School of Social Work at the University of Windsor in Canada. He has over 2 decades of experience in HIV community-based research focused on equity, service access, and policy context shaping prevention and care. Over to you, Adrian.
Thank you. Hi, everyone. I just want to say how much I appreciated this invitation and opportunity. I just want to acknowledge my colleague, Professor Carol Strike from the Dal Lana School of Public Health at the University of Toronto. We co-led this project together. And in the time I have, and I'm going to be very mindful of my 7 minutes, I'm going to keep my presentation at a very high level. And if you find it interesting, I'm happy to refer you to kind of other literature. So next slide, please. In Canada, it's customary to acknowledge the traditional territories where research was conducted. This work took place across multiple territories, and I just want to acknowledge or recognize that Indigenous peoples in Canada have been disproportionately impacted by HIV. Many of the issues that I'm going to talk about today, but have demonstrated tremendous resilience and leadership in the face of ongoing colonization. Next slide. So just to briefly situate the Canadian context, there are an estimated 65,000 people living with HIV, and overall kind of positive progress along the care cascade or continuum. However, there is a considerable regional variation. at the same time, Canada is in the, as much of North America is in the midst of an ongoing drug toxicity crisis driven largely by unregulated fentanyl and its analogs and other adulterants in the drug supply. Non-medical benzodiazepines, other sedatives and tranquilizers like xylazine, and they're all associated with increased HIV risk and risk of overdose and death. In Canada, we have an estimated over 53,000 overdose deaths in the last 10 years. Next slide, please. So this context contributed to calls for a safe and regulated supply of drugs. Oh, if you could click again. This concept was initially advanced by people who use drugs. So that first one was a concept document, a 2019 concept document from the Canadian Association of People Who Use Drugs, calling for a safe and regulated supply of all psychoactive drugs. Thank you. This idea of a safe or safer supply can exist across a continuum. You may have heard about the Drug User Liberation Front in Vancouver, made international headlines. They were offering like a compassion club model. They were sourcing drugs and testing them and then distributing them to community. And then there's more of a kind of clinical medical model. So in 2020, and partly in response to COVID, Health Canada issued guidance that made it easier for clinicians to prescribe pharmaceutical alternatives to the toxic street supply. So opioids, benzodiazepines, and some stimulants. And this model is still quite clinical, but operates largely outside of traditional addictions treatment frameworks, in an attempt to increase access, reduce barriers. Next. So this is the paper that we published, and I just wanted to kind of take a moment to say I first heard about this idea of safer supply in 2019, and it was an early prescriber, a community physician who went public to share that she was doing this kind of informally in her clinic. And she described getting calls from hospitals in her community saying, we have someone here with AIDS, palliative, and we need to discharge them. We don't know what to do. Can you help? And when she spoke to those patients, many of whom at the time were engaged in survival sex work, they would say, look, if you want to help me, you can write me a prescription for something I actually need. And by that, they meant opioids. And so she did. And then described kind of these remarkable changes that would happen when that was the starting point. And that for many of those patients, from there, they were able to, initiate HIV treatment, achieve viral suppression, getting patients housed, gaining weight, reconnected to family. These remarkable case examples, and this raised important questions for me and my team about kind of the implications of all of this for the prevention and treatment cascades. And I very much at that moment kind of imagined this future paper. And so I'm so glad that that worked out and that I also have this opportunity to share this with you. So next slide. So across Canada, Health Canada then funded a number of pilot programs that offered both the prescription piece and wraparound care. Our study focused on 4 of the very first programs in Ontario. And basically they were premised, it was a combination of observed slow release oral morphine as the backbone, and then hydromorphone immediate release tablets to take home, use as desired, including injection. So you could take the medication and inject it. Next slide. I'll just say it was a qualitative study. Next slide. We interviewed 52 patients across the programs. Again, if there are any questions, I'm happy to answer them after. And then next slide. They all had long-term opioid use and had tried kind of conventional treatments like methadone. Next slide. the sample providers that's in the paper is 21 healthcare providers, so affiliated with these programs, physicians and nurse practitioners who did the prescribing, and then nurses and allied health professionals who supported the wraparound care. Next slide. Really, like one of the strongest kind of themes was that safer supply worked as an engagement tool, almost like a pre-cascade sort of engagement tool, just getting patients or potential patients to be willing to re-engage in the healthcare system. So many had experienced marginalization, stigma, medical violence, that this is what took to, initiate even a conversation. Next. Oh, sorry. And sort of once engagement and trust were established, providers described opportunities, to address other health needs, and then the conversations could start very kind of gently around, would you be interested in HIV testing? Then conversations about treatment initiation and practical support, such as coordinating medication dispensing. So on a very simple kind of end, you could get your safer supply bundled with your HIV medication, but in terms of like the bells and whistles, the programs offered support with absolutely everything in people's lives. These were health teams, social work, links with housing workers, and so it was a wraparound care, trauma-informed approaches. And that offered like a really truly comprehensive model of substance use health, as so many people have called for, was enabled through these pilot programs. And next, providers really just described like striking outcomes amongst their patients, again, who had all kind of been considered extremely difficult to reach, if not impossible to reach and engage. And these just, fantastic, transformative kind of results out of all the patients, and this is a quotation, came to safer supply with a palliative designation. 100% of them are still alive and no longer palliative. The patients who came to us with untreated HIV that had actually progressed to AIDS, 96% were virally suppressed and on continuous HIV treatment, and so on. And this is fantastic. And of course, also other pieces, the social worker in me, in particular, was so moved by the stories of then like family reconnection and integration, and all of these other wonderful things that came along. Oh, I'm well over 7 minutes, so I'll just comment on the next slide. So kind of future directions. So there's two ways to answer this. On the one hand, this was qualitative work. There's a growing amount of qualitative work that aligns with this, and also some administrative health data as well that shows this is a very promising intervention. And the next step would have been to start to do work on kind of cascade aligned intervention research, examining comparative effectiveness across different safer supply models, using different drugs, formulations, and dosing strategies, and their different impacts on individual kind of stages of the cascade. Unfortunately, the reality has shifted dramatically, and in the last 5 years and a bit, we went from the promise of safe supply to this backlash to harm reduction that's happening across North America. In the Canadian context and where I live, many of the programs were they've lost their funding. So safer supply as a model can continue, but the wraparound care is no longer being funded. So many of the programs closed. Traditional harm reduction options, supervised consumption sites, needle and syringe exchange is all being kind of scaled back, and the research focus has shifted to understanding the consequences of this. So what happens to folks who are doing so well on this model, and then are deprescribed or forced to move to a model like methadone that doesn't work for them, and also concerns about what's going to happen in terms of HIV and Hep C when you no longer offer traditional harm reduction programming and intervention. So it's just a very, very concerning time. So, and I will end there, and apologies for going over.
Thank you, Adrienne. So now I'd like to invite all the panelists. So thank you all for your excellent presentation. So the next 10 minutes we'll have a discussion, and then we'll open it up to all participants to share of the work that you do in this area. What are your thoughts about what are some existing research gaps and questions that you may have for the panelists? So my first question to the group, to the panelists, is we know that long-acting injectable have arrived. So last year with Cabalet, and then this year with LENS. So what do you see in terms of like the change that will be made in terms of your work? So maybe Shauna, to start with you, when you mentioned that the 2026 guidelines are coming up. So I don't know if you can share with us a sneak preview in terms of what is the implication in terms of the arrival of long-acting injectable from a data system.
Thanks, Mary Claude, and really nice to hear the several different presentations. On the data side for long-acting PrEP, I think it's perhaps less complicated than we think it might be. Honestly, for the indicators, and we've been working on PrEP indicators, I don't know, since 2017 or 2016 when it first came out. The main difference is the formulation. So rather than having oral or vaginal ring, there will be a new formulation which will be injectable. What will be different, and which countries will then have to decide on how they implement it, is the capturing of the repeat injections. So they will all be coming in and having appointments at different times. But I think from a data perspective, if we capture the date of the first appointment and the date of the future intended appointment, then that could do it. But it is a little bit more complicated. It might have a little bit more computing power. But in terms of the broad disaggregation of, say, the proportion of people who started PrEP who were on long-acting versus oral, I think would be perhaps less complicated. But we'll have to monitor people at different time points because they will be given medication for different ones. But I think from our perspective, we anticipated this in the guidelines that we released, so it will just need short updates. And I'll just add, similar to that, for all our digital tools that we have, I didn't mention those, but we have a DHIS2 tracker, we have the digital adaptation kit for national information systems. We'll just fold in PrEP into those.
Thank you, Shauna. Others that would like to add to this in terms of what is the implication of the arrival of long-acting as part of your work? Yeah,
I'm happy to jump in. So a couple of things. I think we've already, and I think we've talked about it a little bit now, but so we've already been doing a sort of dynamic choice of long-acting cabotegravir in this case in community settings, and that's acceptable and feasible and improves uptake and also improves retention. And we are going to start with lenacapavir, which we think will be even better in the sense of being able to reduce the amount of visits that are required down to 6 monthly, potentially with contraception 3 monthly, but much less frequent. So I think, again, making it easier to do a community-centered delivery model. On the positives, I think many of these person-centered care models will be easier with some dynamic choice. The negatives, I think, are that obviously oral PrEP could potentially have demedicalized further, in that you could have a dispensing by a nurse or a doctor or a pharmacist and then delivery in the community by a peer, which currently under most governmental guidelines is not possible with injectables because it needs a professional, whether it's a nurse or a pharmacist. So that adds this level of remedicalization that I think we hope to move against. And so a long-acting oral option may overcome that, for example, and we know that's potentially on the way. But I think the biggest issues are currently cost and delivery. So we're hoping the generics come in as planned and that the kind of availability goes up at the rate that's going to be needed more than the actual delivery. I think delivery is straightforward.
Thank you.
Yeah,
Others that would like to add?
Yeah, I would like to add that on the same line. So I agree that, like, also for the pregnant and postpartum women, we saw that there's a huge stigma involved also with oral PrEP. They want to hide or not disclose that they are using it. People are thinking that they are living with HIV instead of preventing HIV. So I think in that sense, lenacapavir really offers a discreet prevention option, which oral PrEP is now maybe missing. And also in terms of adherence, yes, it's straightforward. If you can offer one injection, which works for 6 months, instead of having to remind yourself, I need to take a pill at 8 o'clock in the evening or something, it's a positive side. And indeed, I think availability is a big question mark, and the costs. For Zambia, for example, in December, the first 500 doses for a whole country were shipped into the country, but yeah, 500 doses is not not sufficient for a whole nation. So hopefully, the future will bring some positive news as well. Thank you.
Thank you, Nkei. Yeah. Adrienne, a question for you. I think that it's a very innovative model in terms of the safer supply. I'm interested to hear more in terms of at the policy, what has been done in order to have a conducive environment and to support the effort, and also kind of the scalability of this model.
Yeah. So in 2019, our previous prime minister had been approached about this, including in sort of public forums, and was on the record saying that he would be supportive, and this made headlines, and then when we moved into 2020, as everybody knows, like everything changed in the context of COVID, and Health Canada kind of just released this guidance that sort of saying like this is permissible, and that non-addictions medicine experts, so general practitioners, nurse practitioners, could start to do this. Beyond that, there was not a lot of guidance across the country. There are so many physicians who don't know this is even permitted, and so are not necessarily offering this in their own practices. The decision to fund the pilot programs was both a fantastic idea, but then so much of the attention focused on those programs, which then focused on some of the highest acuity patients, because they had to kind of triage who could get in, and then from there, after about 2 years into this, the media suddenly decided that this was something that needed to get talked about, and the national conversation emerged around the potential diversion of medication from these programs. And it was all over the news, and the kind of police getting involved. So it was less of like a clear kind of policy direction with lots of opportunities to kind of think through implementation, and an emergency response, which then kind of took on a life of its own, and unfortunately became this sort of this media spectacle, and that a lot of people who I think were doing really well ultimately lost access. There was an election, and the government kind of decided to not continue to be active in that space and to fund these programs, and it's really quite sad. I don't know if that answered your question.
Yes, thank you, Adrienne. Miriam, I have a question for you. As you were presenting, I think one of the things that I found really striking is that your intervention was really able to reach population at high risk. You presented 30% had STI, a high proportion access contraceptive services for the first time. So I would love to hear more about what are the strategies that you use in order to be able to reach that population. So was it through the use of peers or community engagement? So if you would like to elaborate, because I think the data really speak about that you were able to find that population at high risk.
Yeah, so I think that's the peers, I think, had a substantial role in that, and it's because they are peers, so they're aged 18 to 30, they're recently matriculated, they're selected by their both the traditional and the municipal leadership within the community. They then undergo training and assessment. So out of that, we sort of choose young men and young women that pass the assessment, but also are kind of very embedded in the community. They live in the communities, and they are supervised actively through using that electronic clinical management tool with a kind of weekly case-based management discussion, so they sort of learn on the job, but they're also paid like a community caregiver would be, so a stipend equivalent to a lady health worker or a community caregiver. So that sort of combination of them being partly professional, but also being very embedded in the community has meant that they know very much who are vulnerable in their communities, beyond just sort of whether they're having sex, but actually, are they overseas? Are they orphans, vulnerable children? Do they come from a challenging family? The teachers reach out to them about young people in their schools that they're concerned about. So they have a good handle on who's vulnerable in the communities to begin with. And then they have this one-to-one conversation with the person. They do a needs assessment where they kind of grade what the actual content of the need is, but also the degree of the need. So again, that helps them sort of get people that are most vulnerable into services. On the other side, I think the fact that the services are accessible, where we go is where the peers have defined as accessible, and also that the sexual reproductive health is integrated. So they're not HIV services, they're SRH services, in which HIV is part of the SRH package, rather than being HIV services in which SRH is part of the package. And I think that's helped overcome some of the stigma. We still, as Annika talked about, we still suffer with the stigma of a tablet a day and the rattling. So that's still there, but at least some of the other hurdles have been overcome.
Thank you. Wow. Enki, I will ask you a question and then we'll open it up for discussion and comments from the larger group. So Enki, you conducted the systematic review in the time of the oral prep. The methodological heterogeneity prevented you from doing a meta-analysis because there was so different kind of approach. What do you feel was strengthened in terms of evidence generation and synthesis as we go forward with long-acting injectable?
So your question is, what did we learn from?
Yes, and thinking about going forward in terms of being able to do meta-analysis and like advancing the science in this sphere, like kind of the takeaway that you hopefully for long-acting will be doable.
Yeah. As in terms of approach, I think the integration of HIV services into ANC, so like the same as with Mariam, integrating HIV into SRH really helps to improve access. So definitely lenacapavir can be introduced in such a setting. And then I think if we look at from the data science, from the data collection side, I think Shona is maybe more appropriate to call on that. But we also had to request when we were dealing with the rebuttal, like, can you propose a new way of collecting data or harmonizing definitions? We didn't have a straightforward answer because, it's so complicated. Everybody has its own system, its own definition. There are the WHO guidelines, but if everybody's using his own mix, so I hope for the future, then maybe if we could streamline that more, and then if people keep more an eye on the guidelines or the indicators presented as such, it would make our lives easier for comparability of between studies.
Thank you, NK. So Shona will definitively look forward to see the guidelines, the new guidelines. I will open it up to the larger group, so please feel free to either use the chat or come on mute to ask questions or share about your work, and also reflect on what are the research gaps related to person-centered care. How can we advance the science and the implementation of PCC? Yeah.
Thank you, Marie-Claude, for moderating. This is Andrew. I wanted to ask the group about their thoughts regarding the last mile for viral suppression. We have this persistent 7, 8, 9% of people who have unsuppressed viral load and who are very difficult retaining care. What are your thoughts about moving the ball to that 95% viral suppression target?
Andrew, I can make a start. I think one of the benefits of a very good prevention program is that you potentially reach people who are at risk of HIV or living with HIV who are not yet aware of their diagnosis because they're coming in for prevention. And we often, as you can see, we find quite a few, particularly adolescents and young adults and men particularly in our PrEP programs using the peer-led model and the SRH program that are living with HIV not yet aware of their diagnosis and first start treatment. So I think there is benefits in, because I know there's a lot of pressure now with the lack of funding to push HIV treatment back into services and move away from the community delivery models that we've had. And I think those community delivery models are an opportunity to both improve prevention, but also improve finding the people who are either not on treatment because they don't know yet or have dropped off treatment for whatever reason and feel afraid to go back in. So I think linking treatment and prevention is one way of overcoming those barriers. And the second one, as I said, I think is SRH is something, sexually active people are more worried about pregnancy than they are, and STIs than they are necessarily about HIV. So integrating treatment and testing and treatment with SRH services is another way of reaching some of those people that may not yet be in care.
I can come in with another thought, if that's okay, Mary Claude.
Sure, please
Andrew.
go ahead.
So, Andrew, I'm wondering whether your question is really around, for those people who are unsuppressed. I mean, there's all the treatment considerations, but since this is about prevention and getting to prevention, I wonder whether your thought is on making sure that the partners of people who are unsuppressed receive appropriate prevention. And I think that is challenging in many ways, but of course, I have data on the mind all the time, but I really do think that information, again, that's collected every single day as part of routine clinical care, needs to be used to link people to appropriate services. So if you have somebody who is virally unsuppressed, then ensuring that their sexual and drug injecting partners are appropriately linked to HIV prevention is really critical. And I think having data systems that capture that and flag individuals who are either having trouble accessing care, to Miriam's point on community-based delivery versus facility or whatever is the cause. I think making those linkages through data systems that are already there could really help.
And as you said in your talk, only 2 countries had complete data linkage. That was very sobering. I think my question is really about groups left behind, adolescents and heterosexual men, especially in Africa. We have consistently done poorly among children, adolescents, and men. And at least in East Africa where I work, PrEP is sort of viewed as an intervention for adolescent girls and young women. And the only thing we've really done for men is male circumcision, which is now defunded. So just getting those remaining groups in care has really been a challenge. So that is what my question was aimed at.
Any of the panelists would like to reflect on that?
There's a question from Daisy in the chat.
Okay, perfect. Daisy, given the limited supply of lenacapavir, there's very clear existing demand. I feel this should be a research gap, and as a PCC advocate, I'm here wondering what can be done to ensure equitable access, meeting client preference and need, and supporting scale-up rollout, and how can these gaps be addressed? Daisy, I could not agree more with you. So how we make sure that individuals with high risk of HIV have access to LENS, focusing on equity, access, and uptake. Any of the panelists would like to share? And I think, like Andrew, this is tied to your point that you posted in terms of presented data. Andrew Hill presented data at CROI showing that capillary and LENS account for only 2.9% and 0.6% of global PrEP use, underscoring the work still needed to scale up long-acting injectable.
Yeah, I think linked with Andrew Hill's presentation at CROI, first, the medication needs to be in the country, which is currently not the case. So there's no access yet to it, in my opinion.
Other thought comments? Question from Andrew. What surprised you about your study findings?
I can jump in to start again on with the data lens. I think what was surprising for me was that every surveillance system didn't even have, an age or date of birth, sex or gender captured. And for unique identification, there were several that were using personally identifying information in the ID itself, which really is not a good practice. So, sometimes I think there's so much information out there, but there are still some really fundamental pieces in health data that are missing that are really, really important for us to be able to understand who is accessing services, and particularly for prevention, because it's this, on and off cycle as people use it as they desire it. So being able to track individuals to see whether they receive the services they need, unless you can do that, we won't be able to fix, who is getting it and who has access and who could have potentially received it but did not. So I think those were surprising. And also, the fact that we've been talking about linkage to treatment for so many years, but linkage to prevention was really very, very difficult, other than, for a few key testing indicators and vertical transmission. For some of the others, they're just, huge, huge gaps in who could collect that information.
Thank you, Shauna. Others? What surprised you as part of your work, your study finding? Yeah.
I can go if that's okay. So a few things. We went in, so this was very early. Our project technically was funded before Health Canada kind of formally sanctioned this. And so we thought it might be shut down at any moment. But, ultimately that worked out. But our focus was very much around the medications. So wanting to talk to the clinicians about, kind of dosage and titration and these kinds of questions. And then with patients, like how did you get on the program and sort of enrolling, like these kinds of things. Those were not necessarily the things that they were most interested in, and especially the patients really wanted us to first and foremost understand, like, I would not be alive if it weren't for this. The overdoses were really spiking at the time, and just really, wanting us to know, like, this is a life-saving intervention, and then wanting us to know about all of the other ways that, it's benefited them. I made that comment earlier about sort of like social integration, and to hear people say, because of this, I can now see my children. Was not something that I was expecting, but was lovely. Something that really surprised me was that with this medicalized version of safer supply, and again, there is a community alternative, but I was surprised that many of the issues, the tensions from like the methadone model of care, so the urine drug screens, that are very, very contentious, that people describe in terms of surveillance. They say it's disciplinary, that they feel humiliated having to do this. In the context of safe supply, when it was kind of framed as part of people's care, when they could decline it, so they didn't have to do it. Suddenly it became this like thing that they wanted to do, and so many people spoke positively about the urine drug screen process, that in some cases, because people still used other unregulated drugs, so it served as a form of quality control, right? So, I bought this substance yesterday, but it's not showing up on my urine drug screen. It's kind of stuff. So it really spoke to, you can have kind of the same requirements, but if you are delivering them in, a non-judgmental kind of, kind of positive way, you're going to have very different responses from patients. And of course, I knew this, but it just was interesting the way that it would come up. And a very concerning kind of surprise was that while the prescribers were very, very excited about, and I should say none of them were infectious disease specialists. They were all like general practitioners, but they were so excited about the implications for HIV, for Hep C, and other STBBIs. The patients or clients of the different programs, they really did not want to talk about HIV. And I have a lot of experience interviewing people around, in particular, gay, bisexual, and other men who have sex with men, around either, PrEP or U equals U. And, they're very happy to talk about these things and their lives in relation to them. There was so much discomfort still, and this is in the last few years, for so many people to even just talk about HIV. And so I appreciate that for many people, the imminent risk of overdose is their primary concern. But I was quite surprised at how much stigma there clearly still is amongst people who use drugs. And so, I think in some contexts that, that explains why we're not reaching some folks. So sorry, that was a very long answer.
Adrienne, thank you. And I think stigma is true also for HIV, for PrEP, for ART, as well as people who inject drugs. So thank you. Daisy posted a question, Shana, for you. So I'm not sure if I missed it, but on monitoring, it was clear how it was done from registration to HIV testing as the second step, but I missed how risk is monitored in the process that informed the testing. Yeah, key population as a sample population.
Sorry, I'm just reading it in detail. So what we have in our guidance, and I didn't talk about that, was assessing elevated risk of HIV in order to offer any sort of prevention option. We have, based on the evidence that was available at the time, the key risk factors for HIV, future HIV acquisition, mainly STIs in the last 6 months or last year, having a partner with known to be HIV positive, having a partner with unknown status, those sorts of risk factors that we collected across several different population groups, whether that's pregnant women, partners of people who are positive from different trials. But I think the main thing from a data perspective is twofold, and I had this in my slide, but I took it out because of time. One is there are people who will self-express to come that they are at risk. They would like some form of prevention. And so our guidance is not to only provide prevention options to people who meet some threshold or some criteria, but to keep it open, because there are people who may not wish to disclose the reason for which they would like to receive PrEP, and that's absolutely fine, and it doesn't need to be recorded in the system. But on the flip side, many people don't think about that, or maybe they do not evaluate them or see themselves as being at risk. Risk perception is often poor, particularly among adolescents, and people who have just a few or single partners. And so for that reason, having data where, for example, you can see that somebody's tested for positive for syphilis in the last few months, it just generates a question for the provider to say, have you considered HIV prevention? Because clearly that's an indicator of having unprotected sex and being at risk. So that is there, and we do look at that. And so there is that measure of elevated risk that you could capture in a data system, but it shouldn't be the only criteria. So I hope that's clear. You could collect it based on several system level indicators like an STI or partner status or having been on PEP in the past. That should be flags to offer prevention, but also people who ask for it should get it.
Thank you, Shona. This brings us at the end of our meeting. I would like to thank all of our panelists for sharing your work, sharing your expertise, as well as your insight in terms of research gap related to PCC. A big thank you to all the participants who attended this session. And then we'll continue the work focusing on person-centered care. So Emma, over to you. Well.
Thank you so much. Thank you, everyone, for your engagement today. It's been a really good discussion, and I'm excited for tomorrow. We'll continue this discussion. So anyone, in a Europe or Africa-friendly time zone that might be able to join the call tomorrow morning with the team joining us from Asia, please do join us, and we'll have our third guest editor join that session. And Andrew will also be sharing some highlights from the discussion that we've had today. So thank you all again, and please stay in touch with the Research Collaborative and the Person-Centered Care Program, and we look forward to connecting with you in the future. Thank you. Have a good rest of the day.